Good morning, good afternoon, good evening, uh, or maybe even the middle of the night for some of you. Thank you so much for joining. This is episode number 22 of the Unboxing AI weekly webinar series. In case a few of you missed me last couple of weeks, thank you for joining back. I am still very much around. And for those of you who are here, who are new here, who don't know what CARPL is, well, CARPL is your friendly neighborhood AI platform, right? We sit between this entire ecosystem of developers of AI and consumers of AI, helping you navigate, this weirdly complicated ecosystem where you've got hundreds of people building AI. How do you test them? How do you monitor them? How do you consume them? There's so many widgets, so many viewers. We simplify it all uh, through a single platform. Today, we are joined by a very dear friend, mentor, advisor, Dr. Suresh Mukherji. I first met Suresh in Bangalore at the IRIA, which is the Indian Radiology and Imaging Conference. And, suffice to say, uh, one sec, what just happened? Sorry. And suffice to say, it was a very alcohol driven evening. So I don't actually remember much. But what I did realize was that, and my dad told me this later on, was that you don't know who you were drinking with. That guy is like the father of head and neck imaging and this and that. And I just thought of him. I actually thought, Suresh, that you were about at least 20 years younger than than what it ended up being, and like that. So that's how this friendship relationship started. And Suresh has an illustrious career, as I'm sure many of the people on the call already know. um, Widely considered the authority on head and neck imaging. I think was the chair of radiology at University of Michigan, chair of neuroradiology for a very long time. Currently, Suresh is a professor of radiology at the University of Louisville. He's a professor of radiation oncology as well at the Robert Wood Johnson Medical School at Rutgers. He has a position at Michigan State, Texas A&M. Of course, he's the director for head and neck imaging at ProScan Imaging. And then, interestingly, a Bruce Bradley Fellow at the Leapfrog Group, which is something, Suresh, that we'll dive deeper into. Apart from that, he also has positions in Indonesia and in India. So yeah, Suresh, thank you so much for joining in today. It's truly an honor, and thank you for taking the time.
Hey, thanks for having me, Vidor. It's a pleasure to be here. It was wonderful meeting you at the time, and it's thank you for inviting me to this webinar.
Oh, wonderful. So, Suresh, um, why head and neck imaging? What's the story there? Like, how take us back, whatever number of years, decades. How did you end up in neuroradiology? Why that? Why head and neck? What does that journey look like? Let's
All
unbox
right.
Suresh before we
All right,
unbox
unbox it. Yeah, there you go. Okay, so you're ready. So I was born in the last century. I hate to say that. So
AI. So
back in
was
the last century,
I.
so back in the last century, we did have CTs and MRI scans, believe it or not. But when I was in medical school, so I hate to say this, I went to undergrad from 1979 to 1983. So I just turned 63. So I guess I can say that publicly.
The
I
20
went to
year the
medical
20-year delta still remains, Suresh.
So I went to med school in 1983 to 1987. Now, during that time, and this was sort of parallel to, I didn't really know any much about this, but CT was sort of being integrated, and there were a few MRIs being done. And I remember as a first year medical student, so this story has sort of three parts to it. I'll be really brief, but I remember sitting in med school in my neurology lecture, and somebody showed a brain MRI, sagittal brain MRI, and it just sort of flashed up there. And I'm like, this is really neat. This is right then I realized, the future of image of medicine is not necessarily going to be, with all due respect, palpations and trying to make indirect diagnosis. this fascinating new technique to actually look inside the body and actually see pathology and eventually, treat based on what we can actually see in our pictures, as opposed to at that time, we don't have enough time to go into about all the decisions that we make just on physical examination. And, it was okay to make mistakes because there was an expected error rate at that time. Now, if we try to practice this medicine now, it would be malpractice. But, I sort of, at that time, I was like, this is really going to be revolutionary. So that was my first kind of snippet into radiology. And then about a year later, again, truly from happenstance, a friend of mine from college invited me to go to this party in DC, and I was in med school at DC. So I went to this black tie party. I didn't know anyone because I was just a lowly medical student. You had all these business guys. So this is the roaring 80s when money was just falling off the trees. So somehow I pieced together a bow tie and a jacket that didn't match. And I happened to sit down at a table. And this one guy was a nuclear medicine physician. And so I talked about my interest in research, and he offered me a fellowship. So that really first got me into radiology, again, purely by chance. And then I decided to apply for residency in radiology. And then the second day of my residency, I was on my neuroradiology rotation. I remember my fellow and my attending literally taking a paperclip, because this was in the days, again, in the last century, we didn't have PACS. We actually had something called film, Vidor, and you and others can go back and YouTube what film looks like. But we had something called alternators and film. And I remember them taking a paperclip and like unwinding it. And so we didn't use mouses back then. There were no critters back then. We actually used paperclips. So I remember taking the paperclip and pointing at all the skull base foramen. And all of a sudden, I realized all of this silly and minutia anatomy that I learned back when I was a medical student, actually, we can use that in our day-to-day practice. So for some reason, the second day of my residency program, once I was introduced to radiology, I sort of saw the power of it. I got indoctrinated into doing some research. And then on that day, all of a sudden, I'm like, wow, all these great things that we can see, it was complex, but it was really rewarding. So I just fell in love with head and neck radiology my second day of my residency program. And at that time, no one really did it. It was kind of an anathema. No one was like, yeah, why would you do something like head and neck? No one ever does it. It's difficult. Why don't you do something else? But for me, I think that was part of the challenge. And to be honest with you, now that I'm senior, I have more yesterdays than tomorrows. Um, I kind of look back on myself and I said, would I do the same thing? And I would do the exact same thing. I wouldn't change a thing. I absolutely love what I do. You know, I uh, I love the innovation. I love the anatomy. I love the challenge. Every day I see something that I've never seen before.
Mhm.
It makes me a little bit um, scary in the sense that there's this fund of knowledge that
Mhm.
I've missed. But on the other hand, what I realized I think I was the smartest radiologist when I finished my fellowship, and the older I get, to realize how much I don't know. So it's a combination of
That's
excitement and
just
also
I
humility
think
as you get
Suresh,
older.
there's so much to learn in that one statement for everybody building out their careers at the start, right? That even someone like you can be so humble. But tell me one thing, like if you think back, is there any, like, the way head and neck imaging is today versus the way you would have envisioned it, whatever, 35 years ago? Is there any difference, like is there any counterintuitive thing that has happened today, like uh how do you, if you were like Suresh Mukherjee, 19 89, let's say, gazing 25 35 years into the future, and now what today looks like how does that difference turn out?
Yeah. No, it's a great question. I think part of it is, we've been able to successfully integrate a variety of new technologies into head neck imaging. So in the old days it was just CT, then it was MR. But I think what's really pushed the field forward is the, advances in imaging and the better technology that allows us to see smaller structures. I mean, part of the challenge that and the joy that I get is that the liver is a pretty big organ. I mean, the leg is a pretty big organ. Um, But just yesterday, we had a case of a patient that had a cancer involving the palate, and they thought that they could resect it just taking the tumor out by opening their mouth and resecting it intraorally. But just the way the technology has evolved is that we can actually see spread of tumor along 1 to 2 millimeter nerves. And when I showed him this, all of a sudden that completely changed the resection and the staging and how that and the prognosis of that patient. So to answer your first question is the advancements in technology and the ability to see smaller and smaller structures really play into the hands of head and neck radiology. The other thing is to use a lot of these new, I always call them physiological or biological techniques. There are lots of starts and stops. I built my career looking at new physiological techniques as they apply to head and neck imaging, especially to cancer. So some of these have sort of made its way into mainstream, but there are other ones that haven't. And so, every time we do write a paper, or anytime we have more information, we find out something may not work, we've actually expanded our fund of knowledge. So, the integration of some of these new biological tools, the wins are things like PET CT. I mean, right now, my first grant was actually on PET CT for what we call unknown primaries. This was before we even had that imaging, but it's been rewarding to see that's now part of our mainstream culture, and now it's just part of standard of care. And I think in the future, we're going to see even more targeted imaging in head and neck, and also not only to image, but also treat based on target. So that to me is something that I never would have envisioned when I first started radiology, but it's something that keeps me active because a lot of these things were created, developed, envisioned after I finished my residency and after I was established. So, for me, it's
And do you
what's the next
Suresh,
windmill?
do you also see that, like, has the advancement, like just the example that you gave, right? Has the advancement in technology also enabled a general radiologist to be a better head and neck radiologist? Or do you still need to remain at the cutting edge of your training to be able to optimally use each of these technologies?
Yeah, that's a great question. So, I think what one of the big advancements that I think we have made as an organization in the United States, and I see this in Europe as well, just but I came from Europe, is that we've codified the training in head and neck radiology. So
Mhm.
back when I was a resident, the head and neck radiology, the joke was head and neck radiology was radiology nobody wanted because the neuro people wanted to stay above the skull base. The chest people wanted to sort of stop at the clavicle. Then you have all this area right here, which is sort of, no person's zone. Nobody wants to go there because it's kind of weird and it's hard. And, I just want to stay away from it. But over time, what ended up happening is that in general, the neuroradiologist took ownership of education in the head and neck. So again, I have to harken back to the last century when we had something called Certificate of Added Qualifications, which helped establish training in neuroradiology. There were three components. One was the brain, one was the spine, and one was the head and neck. And that was kind of revolutionary for us because before that time, there was no true curricula to help train individuals in head and neck radiology. So I think now, as we are in 2024, over that last 24-year period, the average neuroradiologist for sure, and I would say the average resident comes out, knows it much, much more than that same individual did, back when I was finishing up my radiology residency. And so, kudos to the ABR and the various training programs for identifying a knowledge gap
Yeah.
and trying to address it.
So it's not that's interesting, right? Because it's not just the technology, but it's also the evolution of the training on that technology that has led to this. I think that's a phenomenal point. And just switching gears, Suresh, like, I'd love for you to share some of your experience of working with the Leapfrog group. For folks who are listening in and who will listen in later, can you share a little bit about that? Like, what is the Leapfrog group? I don't want to steal any of your thunder on that sense. So, what's the Leapfrog group? How does it relate to AI? And what's your opinion of all of that?
Yeah, no, thanks for asking. So I have a bit of a unique career in the sense that I spend probably 80% of my time doing head and neck radiology, but 20% of my time has been involved in the purchaser and the payer community. So back when I was in Michigan, I was head of the what we call the Certificate of Need Commission. So all the medical services in the state of Michigan were what quote unquote covered, which means they were regulated by the state government. And when you first look at it, you can say, well, that's a bad thing. But one of the good things that Michigan did was that if you had to have more advanced care, such as a bone marrow transplant or any type of different transplants or even pediatric care, they tended to be centralized to what we referred to as centers of excellence. So that gave me the interest and the basis of learning more about healthcare at that level, but also the emphasis on quality. So the Leapfrog Group is a nonprofit that is the primary watchdog agencies of hospital systems in the United States. And they are the ones that give the famous grade. So if you are involved in healthcare and you are at a hospital, they grade these as an A, B, C, or D, or F institute. So that's where you may have heard of this. So every year, the Leapfrog Group, which is purely focused on hospital quality, chooses anywhere from 3 to 4 fellows. So I was a fellow in 2023, and it was named after the founder of the Leapfrog Group, which is Bruce Bradley. So I had the
Oh.
privilege of being a Bruce Bradley fellow. And part of the reason they had me is because I am the medical director for a couple of healthcare coalitions, and I'm also the medical director for the National Alliance of Healthcare Purchasers and Payers, which represents approximately $300 billion of spend on healthcare by small to mid-sized healthcare systems. I should say corporations. So the the way it sort of ties into AI was every year the fellows have to do a project. So if I put on my radiologist hat, certainly if I'm going to integrate an AI algorithm that's going to help me provide better quality of my interpretations, I certainly think that we should be reimbursed for that in order to provide better patient care. But what was interesting is that when you look at the flip side, so when I look at healthcare as a whole, I sort of divide it up into 6 Ps, which are the patients, the providers, the purchasers, the payers, and the policy and the politics. I've been exposed to all 6 of those. So as a provider, I think if I'm using AI, I should be reimbursed for that. But my project specifically was to interview different healthcare purchasers and payers and get their perspective on artificial intelligence and how it's actually implemented in clinical radiology practice. So for me, the reason I sort of involved in this is that, I want to try to figure out how the system works. And I think the only way we can help move our system forward is by understanding, different stakeholders and their perspective on things. And so that's how this kind of all came about. And that was my somewhat of a unique experience. And look at the other side of
And
AI from a
what
purchase and
were
payer
like?
standpoint.
Can you share like a couple of the key insights?
Yeah, sure. I think part of it is, the purchasers and payers are really overall, they are not supportive of specifically paying for artificial intelligence. They feel that anything that is addressing a specific physician's quality is a practice expense. And that practice expense needs to be borne by the specific provider. In this specific case is the radiologist. So unfortunately, there was sort of close to uniform feeling that was not supportive of helping support disseminate artificial intelligence into our overall practice. Now, having said that, the tension comes
And do
in.
you agree with that, Suresh? Sorry, do you...
No, I don't. No, I don't agree with that. And I think part of it is, and we've seen this recently when the way our system is set up. So if I just look at Medicare, Medicare is part of a prospective payment system, meaning that if we go to a grocery store, the grocery store is going to say, this is the price that you pay. I can change it today or I can change it tomorrow, but this is what you're going to have to pay to purchase that specific good. In our healthcare system, you can look at that as a marketplace as well, too, where I'm a radiologist, I provide a service, and that service is purchased. And that it's either being purchased by an employer that has employees that they have to purchase healthcare service for them, or it can be purchased by Medicare. Now, Medicare and Medicaid actually set the price. And that price is oftentimes set. They always say it's 1 year advance, but I think it's actually more than 1 year. And that's what we refer to as a prospective payment system. So in certain situations where AI has made substantial advancements in care, such as stroke imaging, such as the ability potentially to avoid coronary catheterizations, cardiac catheterizations, they have built in an additional payment. So Medicare has sort of tried to adjust that until they can work that into a future payment system. But overall, no, I think there should be some acknowledgement that there are new technologies that's going to help us provide better care. And then to take it one step further, when I talk to CEOs of mid to small size companies, from their standpoint, they look at radiologists and say, well, why aren't you using every AI tool to give you the absolute best diagnosis?
Mm.
Because we're going to pay you for this. We want the best diagnosis. But then you get into a situation where it's just, financially impossible to do that for every single patient unless we get some type of support. So I think that's where that tension is.
And do you think, Suresh, that there's a day in the future where, uh, a near future, well, who can predict, the farther future, but do you think there's a day in the future where radiologist reimbursement, like those on fee for service, varies based on the nature of the report they have written? Like, for example, normals versus abnormals is a big AI use case, right? Uh, it theoretically possible to power through say 100 chest x-rays a minute, or maybe even 200 chest x-rays a minute, sorry, an hour. So 200 chest x-rays an hour, all of them are normal, you're just going boom boom boom, through that work list. uh, and the case to be made there is that uh, the radiology practice doesn't actually buy that AI system because they still have to pay the radiologist as much, so it really doesn't matter if they can go that much faster. Do you see a scenario in the future where, for example, a radiologist is paid lesser per scan for a normal study versus, more per scan for an abnormal one, such that, they're still making either the same or more in the process, but uh, so is the practice. Like, do you understand?
Yeah, I understand what you're saying, and my hope is no, hopefully not. Um, because I think if we do that, then the way CMS works and when they sort of benchmark our
Or they will
payments,
just look at
they
the normal and just
that would be the new benchmark right now. So I
ah,
have been involved more peripherally as opposed to really on the ground about how we set our RVU payments. And there's a lot of nuance that goes in, and there's a fair amount of strategy that one would never even think of to make sure that we are appropriately reimbursed. They do kind of do that de facto in the sense that our payments tend to be higher for more complex studies as opposed to more straightforward studies. So that's sort of built into the system, but hopefully not with the normal versus abnormal.
got it. Got it. So we've got a couple of questions, Suresh. One is from Amit. So Amit is part of my team. He's a young physician who's now devoted his career to studying the AI ecosystem. So he asks, can you provide an example of a problem where, in your opinion, an AI solution would be highly beneficial, but due to its complexity, it's uncertain whether such a solution could be developed in the near future? Oh, interesting. So you get the question, right? Like something that would be really beneficial, but whether you can actually create it or not is a technical like limitation.
Yeah, wow, that's actually a full talk I can give on that. So I would say this, Amit, I think the biggest challenge, and I'll try to be concise on this, is that part of the challenge, first of all, I think part of the challenge with AI of a lot of these solutions tend to be binary.
Yeah.
So at a big picture level, I think when you actually are developing something, we have to make sure that AI can actually think like the brain. So for instance, if I put a head CT into an AI system, it can say hemorrhage or no hemorrhage. But is it going to be able to comment on the soft tissues of the scalp? Is it going to be able to comment on a calvarial fracture? is it going to be able to comment on a fracture involving, any mass involving the globe? Because the challenge that comes in is that if from a medical legal standpoint, if there's something on the film and we don't see it, we are medically legally responsible for it. So that's why there's a little bit of reluctance to purely base an interpretation based on AI alone. The other thing, to answer your question, is that yes, I think AI is good for things like pneumothoraces. I think it's good for pulmonary embolism, for stroke when it's again binary. But there hasn't been as much uptake to looking at things like brain MRIs or in general, even head and neck MRIs, et cetera, because it's really hard. Even the clinical practice I work with does a lot of musculoskeletal MR, but still we're a little bit reluctant on implementing an MR-based algorithm for spine imaging just because there's so much anatomy and so many complexities and so many things that could go wrong with the spine that could potentially cause that patient's either radiculopathy or any type of back pain. So that's one of the big things that would be incredibly beneficial. Spine stuff is, for me, it's not my favorite. Takes a fair amount of time to do, but if you can have a solution like that, that really would, have a lot of benefits at various in various ways.
So what I'm reading or what I'm hearing, Suresh, is that uh, there's a bunch of use cases you could do, but you'd rather do one and do it like end to end, right? Not have it cover, say, some lesions, not cover or cover or others and stuff like that. So that's interesting. Spine MR, of course, is I think almost 30-40% of all MR. Next question is from Shruti. How do you address concerns about AI replacing radiologists, particularly in specialties like head and neck imaging? I don't think head and neck imaging can be done by AI. Like, I think I'm going to answer that for you. Like, I remember as
Yeah.
an MBBS student, first it was anatomy, and then there was the cranial nerves, and oh my God, we all had those skulls that we would roam around with. I don't know. Do
Yeah.
you think AI will ever replace radiologists for head and neck imaging? Maybe you had that foresight, Suresh. That's the
Oh
one
my
thing
God.
it will
Well,
not replace.
yeah, no. I had the foresight years ago when I first started hearing this concern, and I was like, this is not good. There is even back in 2017, even in my talk on AI, I have the famous quote by I'm blanking on his name right now, the person from Canada saying that we should stop training radiologists.
Yeah, Jeffrey Hinton. Yeah.
Unfortunately, yeah, Hinton, yeah, the famous Hinton video, and unfortunately, what ended up happening, and I can be open on this because we're friends. I think we as a subspecialty really did ourselves a disservice. I think we had a lot of our leaders at the time that were going to our major meetings and saying, well, we have to watch out. Maybe we should train less radiologists. It may replace us. And I don't know if these were really serious individuals or they just wanted to make a name for themselves. But the challenge is that that actually got down to the medical students. And
Yeah.
so for a while there, we actually had a reduced number of interest from medical students because they thought we were going to replace. When I saw AI coming out, there was no way that they're going to replace radiologists. What it is going to do is I equate AI with PACS. Ever since I've been doing this now for 30, 35 years, they've predicted the death of radiology 7 times. And the only thing that's happened is that we just continue to grow and grow. So AI is a facilitator, just like PACS was, just like voice recognition was. It's going to make us more efficient. Our challenge is how do we implement this in our practice, and how do we do it in a frictionless environment such that it can improve our quality, improve our efficiency, and reduce our costs. It's never going to replace us. It's just going to make us more efficient and better radiologists.
Oh, and Suresh, we are at time, but final shameless self-promotion, words. Would love to hear your opinion on the we call it like the CARPL platform approach, right, where everything gets done through a single platform. Like, would love your opinion on that.
No, I think, to be honest with you, I think and I would say this before I met Vidur, is that I think the platforms are the wave of the future because when, what gets me is that, like I said, I'm putting a bunch of talks together over the next month or so. There are close to 350 FDA approved products on the market right now. And when I look at how many are actually being implemented, not that many. And part of it is because of all the challenges of implementation in your system. And it's not only individual implementation, but then you get into what I call rice bowl issues. So if I'm in a big academic center, well, guess what? Radiology is interested in pulmonary AI algorithm. Cardiology is interested in that algorithm, and um, pulmonologists are interested in that. So who owns artificial intelligence? So I think part of it is if you have a platform like this, you can now have numerous products that are available at the enterprise level that any individual within that organization can pull down and use as opposed to quibbling about a certain algorithm. The other thing too is if you want to use more than one algorithm, you have to individually negotiate with each
Yeah.
product, each company. You have to have the back end integration. Again, with CARPL or any type of platform like this is all done for you. And then, based on where the future is going, you can have a scenario where you can run a study through multiple algorithms within your platform automatically, and that's going to help you increase your overall quality as well to make you more efficient. So I think the future is not necessarily one widget, but in a platform that CARPL has, to be honest with you, I think you're just scratching the surface. And I think CARPL has been way ahead of the game. And I think other areas are just starting to catch up, and we're just starting to unleash the real power of this strategic approach to artificial intelligence at various organizations, not only in academic centers, but smaller academic centers, 30 to 50 person groups. And when you look globally at artificial intelligence, it's not just in the US, but what it does allow it to do is provide access. So one of the things that I learned through my experience is that value in healthcare is cost, quality plus access. You can reduce your costs, you can improve your quality, but if you don't have access, you have no value at all. So when you are looking at places that just don't have the capability to have 100-person groups provide subspecialty care, if you can create targeted educational platforms and then integrate an AI algorithm, all of a sudden you can provide subspecialty care anywhere in the world globally. And I think for me, that's the real future and the real opportunity. And that's where I think CARPL has to offer. So I'm actually very optimistic about where the future is for AI when we introduce this type of strategy.
No, thank you so much, Suresh. I think I'm just gonna copy everything that you've said and start saying it in all my sales pitches. No, but thank you, Suresh, and thank you to everybody who joined, and thank you to everybody listening in. Yeah, we'll see you next Friday, same time. Thanks, Suresh. Thank you so much. Means the world.
Thanks
Thank
very
you.
much for having me. Appreciate it.
Bye.
Bye.